we're going to have a lot of work to do on matching patients to the appropriate mode of care delivery, phone follow-up, video follow-up, in-person follow-up, initial assessments. So you bring up a really good point there that what's offered doesn't necessarily match the needs of the patient. Psychiatrists, neurologists, geriatricians, family medicine doctors all treat patients with dementia and sort of focus on different types, but all have a lot of intersecting. It's not just about the patient preference, but it's about the physician preference. And so we are working on some continuing medical education about virtual care for physicians who are not as comfortable.
As the pandemic numbers drop and reopening starts to happen, it's going to be really interesting to see if do we still default to virtual first, or is it now, as Sarah's kind of alluding to, virtual by choice? And then who, when, what, it gets almost more complicated. When we're all in lockdown, it was almost easier because your choice is don't come at all or come virtually, and then we'll make exceptions if we have to. So it's going to get more complicated before it gets simpler again.
Yeah, I completely agree. And virtual care has, in a sense, a triage component to it, getting at least access to the patient and then determining the next best steps.
I think we're going to see that blend. And as Dr. Mitchell highlighted, it's going to be partly dependent on patients, partly dependent on doctors, and partly dependent on the government and what they allow, what they fund, how they regulate, what moves forward. It's going to be fascinating, I think, for the next couple of years as this plays out.